58-year-old female presented with complaint of blurred vision in left eye since 1 month and headache since 1 month. She said she had left-sided body pain and severe backache. On further probing, she had some weight loss. Her visual acuity in right eye was 6 by 9 and in left eye was 6 by 36. Anterior segment examination of both eyes were within normal limits. There were cortical cataract in both eyes. Right eye posterior segment examination was normal, and in the left eye media was clear. Disc was normal, and there was dome-like elevated mass around 8 disc diameter of varying color along the superior temporal arcade with vessels overlying it. So we had differentials of tubercular granuloma, choroidal abscess, choroidal metastasis, or it could be amelanotic choroidal melanoma. Age, history, and clinical picture was in favor of tubercular granuloma and metastasis. B scan, there was choroidal thickening, well-defined homogeneous choroidal mass with high surface reflectivity and low to medium internal reflectivity. So B scan was also in favor of metastasis. Patient was advised to review with oncologist, but she didn't come for follow-up. She turned up after 6 days with worsening of her symptoms. Her visual acuity dropped to 6 by 60. There was whitish yellow choroidal lesion, subretinal hemorrhage surrounding subretinal fluid, and inferior exudative RD in the periphery. OCT was done through the lesion. There was subretinal hyperreflective mass coming from the lesion. This OCT was again in favor of granuloma, abscess, and metastasis. Acute worsening of symptoms and all the other findings were against the amelanotic melanoma. Patient was advised battery of investigation and oncology evaluation, but she didn't come for follow-up. After 15 days, she came with the reports. Based on these reports, tubercular granuloma was excluded, but her AC levels were elevated and there were mediastinal lymph nodes. So can it be sarcoid? Clinically no, as it was a very huge lesion. But the oncologist was not keen on metastasis because there were no systemic evidence of metastasis. There was significant increase in the size of the lesion. On the B scan also significant increase in the size of the lesion was noted. So it is a case of left eye choroidal mass which could be infective or metastatic. Patient was advised to undergo biopsy which was suggestive of malignant cells from the adenocarcinoma. Then the patient underwent PET scan which was suggestive of gastric adenocarcinoma as the primary malignant neoplasm, and there were metastases in her whole body. So it is a case of choroidal metastasis which was secondary to gastric carcinoma without any evidence of systemic features. Oncologist was not keen on metastatic evaluation. HRCT and serum ACE levels were misleading in this case, and biopsy has to be done due to this uncertainty. Choroidal metastasis may be the initial presentation of underlying malignancy. Biopsy can be considered if systemic investigations are not suggestive of malignancy, but we should rely on our clinical examination skills rather than the investigations alone. Due to its abundant vascular supply, choroid is the most common ocular site of metastasis. It usually go undetected, and we should have high index of suspicion in elderly cases to consider the diagnosis.